what I'm going to do is just kind of go over the discussion postings and kind of point out some things that you all did that were good and important to know. So we'll start with that. Discuss the types of hearing loss and their causes. This kind of relates to the anatomy of the ear. You're going to want to know what type of hearing loss there is associated with the inner ear and the middle ear and the outer ear. Okay, and you will see on your boards probably test questions on the Rhine and Weber. So it's important to kind of review those over. It's not something that we can just, kind of forget about once we've learned it. It's something that will pop up again. The ear anatomy that kind of went along with it. Some of the things that mistakes that I see with students are not knowing what is the outer ear, what is the inner ear, things like that, middle ear. So just know the parts of the ear and where you'll find them. That's important also for patient teaching, because sometimes they don't understand that a otitis media, unless there's a ruptured eardrum, that drops won't get in there. The only eardrops we would use for otitis media with an intact eardrum are analgesia drops that we would put on the external ear canal. Okay, and then pneumatic otoscopy, that's to see, if the tympanic membrane is moving properly, and that helps in the diagnosis of AOM. Tympanic membrane rupture. But the main thing I think for a nurse practitioner to know is that the differences in what it looks like when there's a tympanic membrane rupture with lots of debris versus an otitis externa with a lot of debris. You don't want to flush an ear or wash out an ear that has a perforation in it. It wouldn't be good for the ear. Okay, so do we need to culture the drainage? Go ahead and read that over. You need to know, how to treat an otitis externa. Maybe common organisms, things like that. Cerumen impaction. When is it a problem? Now, you all had a pretty good discussion on this as when to remove the cerumen and when not to, and kind of the general rule, and the student has put the quote from Bottaro in here. It's associated with patient symptoms, or you're needed to look at the eardrum, you need to assess the eardrum, or they're having some conductive hearing loss because the sound waves can't get to the eardrum. Differential diagnosis of acute ear pain. I'm sure y'all seeing a lot of this in clinical right now. It's really important to diagnose these appropriately so that you can make good decisions about your interventions. And kind of the rule of thumb is that an acute otitis media, sometimes most of the references that you will see will say that there is bulging of the TM. So you may have opacity, things like that. And effusion, you may see fluid, you may see some little bubbles in there. Otitis externa, you're going to see swelling in the ear canal. You may see redness, swelling. A lot of times I'll see some white kind of liquid debris. But when there's a TM rupture, what I'll see is more green, yellow, more purulent types of drainage. So that's just from my experience, as far as the difference between a rupture and a otitis externa. So just be careful with that. Foreign bodies, we had a nice discussion of the roaches and things like that. Okay, then we're going to get into conjunctivitis. And we're going to talk about the different problems. You're going to be thinking about the different problems with the eye, a red eye evaluation. And so you're going to want to know the major differences between what it will look like when there's a viral conjunctivitis and a bacterial and allergic. And some of those key things are viral occurs with viral symptoms. You'll have a patient that has upper respiratory symptoms and their eyes are red. And bacterial conjunctivitis, usually you'll see the key diagnostic feature there is yellow or green drainage matting. That's how we know it's bacterial. And allergic conjunctivitis is a lot of clear, just watering. You may have a runny nose watery, runny nose, and watery eyes and red eyes. So know how to treat those. Okay, and then we're going to get into this next one is about the nasal lacrimal duct obstruction. And we see this a lot of times in newborn babies. That's kind of what we'll see. My poor baby had the unfortunate event to have this nasolacrimal duct obstruction. He had jaundice. He had a perforated an umbilical hernia, and he had baby acne. So he was not a very pretty baby. So with the dacrocystitis, the main thing that happens is that the first line treatment is massage, and so you can read about that a little bit. You'll probably see that it happens more often than you think. I don't know if any of y'all have seen that yet in your practice. What about conjunctivitis? When do they need to be out of school? They're diagnosed with conjunctivitis. What do you need to know when they can go back to school? Because that's always a big issue, especially with children, because it's really contagious. Good hand washing, things like that. Okay, know the difference in if you have somebody with treatment failure, getting back to the ears, know the difference between treatment failure, recurrent acute otitis media, and chronic acute otitis media. Those are distinctions there that you need to think about. Know the time frames, and when you need to how to differentiate between those different infections. All of them are recurring infections, but is it a recurrent infection, another infection? Is it a treatment failure? Did they not get enough medicine? Did they not take their medicine, or was it not the right medicine? Also, is it a chronic infection? What's the definition of a chronic AOM? And when do you refer to specialty care? So in this posting especially, I think it's good to note that this list of medicines here, alternatives to high dose augmentin include, and if you look at this list, every one of these starts with a CEF. They all start with a CEF, and that means that they're a cephalosporin. And I find it much easier to think about antibiotics according to the class. So if you look at this acute otitis media, if you're going to prescribe antibiotics, look at this acute otitis media sort of presentation that I did. Mainly in acute otitis media, a lot of times you'll see that word bulging. If on the boards and things like that, you'll see bulging is often associated with acute otitis media. So that's kind of your differential diagnosis for that in helping you to diagnose acute otitis media. Factor 1, no evidence for specific drug. That's the evidence. Penicillin remains the drug of choice. It covers strep pneumo. And anything with staph and strep in front of it as a word is always a gram positive. So we know that penicillins cover gram positive, and that was your amoxicillin, your ampicillin, those. Then your extended spectrum add on the gram positive, the gram negative, and they add on the gram negative and the beta-lactam coverage, and that's your augmentin. So if you look here, the first step is treating gram positive. We know that the major organisms responsible for acute otitis media include gram negative, but there's no evidence to start with treating gram negative. Okay, so the next step is an antibiotic failure. What do we add on? We're going to add on a beta-lactamase coverage. And we want to do this in the case of antibiotic failure, and also if there's a high suspicion for a gram negative bug growing, because as we said, the augmentin covers gram-positive, gram-negative, and beta-lactam. So there is no evidence for starting with a gram-negative coverage in acute otitis media. No evidence for specific drug. Penicillin remains the drug of choice. And you'll see that on our little chart here. Penicillin covers gram-positive. Everything with a strep and a staph in front of it, every bug with a strep and a staph in front of its name is a gram-positive bug. Okay? So if there's antibiotic failure, we will want to add on a beta-lactamase agent. So we'll want to cover not only the gram-positive, but also a beta-lactamase coverage for that resistance. Now, if you look on this list of classes, you'll see that every drug that covers beta-lactamase also covers gram-negative. So you can't really separate those two. Once you add on beta-lactamase, then you're also going to get gram-negative with it. So you can see that in all instances, you can't just add on beta-lactamase. So if you see the augmentin here, gram-positive, there's your gram-negative, and there's your beta-lactam coverage. Okay, and so we know that the most common infectious agents in acute otitis media are the strep pneumo, the H flu, and the M catarrhalis. And the strep pneumo is positive, and the H flu and the M catarrhalis are negative. So in the case that you have a patient that has severe otalgia, severe pain and fever, you may want to consider starting with gram-negative coverage with beta-lactam. So you can see on this chart that I have highlighted those medications that fall into that category. Now you can see here in the third generation cephalosporin, you have weak gram-positive coverage, plus gram-negative and beta-lactam. So the third generation coverage is the extended spectrum is probably better. And the fluoroquinolones, this is Levaquin. This third generation fluoroquinolones, we don't really use that one very much. I save this drug for the big boys and for only when really needed, and you probably won't be using this drug too much in pediatrics. We need to save these drugs. And I asked questions in the discussion about azithromycin. Now you can see azithromycin is gram-positive and gram-negative, but we don't have that beta-lactam coverage. Atypicals are mycoplasma, and that's usually a lot of times a pneumonia. So these drugs are real good for the chest, these macrolides. So just keep in mind when your patient comes in and asks you, they have an acute otitis media, they ask you for a Z-Pak, azithromycin, you're not covering beta-lactam. So you know more than they do, okay? All right, so if you notice each one of these, except for one, is a third generation broad spectrum, extended spectrum. So if you just knew that it was a third generation extended spectrum, then you are going to know that it starts with CEF, right? That's a little memory hint. Hearing loss, think about that. Hearing loss in children can cause decrease in development, so it's a big issue. So if you have a chronic effusion, or you have a chronic or recurrent acute otitis media, that can affect their hearing. Okay, so in this one, how many questions are there? There's only 4. A patient reports a penicillin allergy. The nurse practitioner would want additional information about the type of reaction before prescribing the antibiotics. Which class of antibiotics? So we know that there is a viliform rash that you can get with a penicillin that is not the same as anaphylactic rash. Okay, so there's a cross reaction between penicillin and cephalosporins, so that's probably the answer to that one. Let's see. And then I'm going to move to the next question. A patient is diagnosed with swimmer's ear and exhibits tragal tenderness. What other problems should the nurse practitioner be alert for? Okay, so we got sensory neural hearing loss. No, that doesn't make sense because that's in the outer ear. So a swimmer's ear is a otitis externa, and they can get swelling, and the sound waves can't get to their eardrum. So that wouldn't be sensory neural. So otic itching, yeah, that's pretty consistent with that. Fever, otitis media. No, I'm probably going to go with fever is not, and otitis is not on my, they shouldn't normally get a fever with otitis externa, and otitis media is something different. Okay. A 3-year-old girl was treated for acute otitis media 4 weeks ago with amoxicillin. She appears today with bulging, reddened, opaque TMs with a fever of 101. I'm going to say she has acute otitis media based on that assessment. She has had pain with difficult sleeping times 2 days. Not important. Okay. She's hurting though. Hurting is important. Because that's one of those diagnostic things that you're going to take into consideration, fever and pain, when you make your antibiotic selection. So prescribe antibiotic with beta-lactam coverage, prescribe decongestants with analgesia. Analgesia is important. Eustachian tube dysfunction is the reason for acute otitis media. That's why people get it, because that eustachian tube gets clogged up, and then they can't drain. Their middle ear can't drain, and that fluid gets stasis, and then it's a good environment to grow bacteria. So analgesia, decongestants, I'm not sure that's evidence-based, so I don't know about that answer. Refer to an EENT physician for specialty care. Now, is this antibiotic failure, or is it a recurrent infection? I think the cutoff is 4 weeks, so this is probably a recurrent infection. And parent education with symptomatic treatment. No, I'm not going to just treat her symptoms. I'm gonna give her another antibiotic because she's ill. Now, it could, be this one. I'm not sure that she is considered a recurrent infection yet. I mean, a chronic infection yet. So let's kind of hold on that one for a little while. Let's try beta-lactam coverage. And we know that if you include the beta-lactam in all of those antibiotics, she's going to get gram-negative. So if it was H. flu or M. catarrhalis, she's going to be covered. Which is the most common organism found in otitis externa? I'm going to go with this one based on my knowledge. Okay, so I'm going to save it and submit. And then down here in the corner is an OK. Got that one right. Tragal pain is classic. Itching is also frequently seen. Anaphylactic reactions, you can see that feedback there. If narrow spectrum antibiotic fails in acute otitis media, add a broad spectrum antibiotic with beta-lactam coverage. Okay, and the common organisms. So I think I got 100. That makes sense since I wrote the test. But you know me, I would probably forget the answer by the next time I read it. Okay, so this is talking about antibiotics, overuse in acute otitis media, and I think probably you all understand the reason for that. It's kind of beaten into your head to not prescribe unless it's needed, unless it's indicated. And then now we're going to get into the eyes a little bit. We're going to look at the styes, and you're going to want to know the difference in treatment between a stye and these various chalazion and blepharitis. You're going to want to know the treatment and be able to differentiate those on exam, and be able to. These are lovely pictures. Are we going to poke those? No, we're not going to poke those. Okay. Do we prescribe antibiotics for those first thing? Check on that. No, if you're going to prescribe fundoscopic exam. If you look in the course, I put a little something in there in units and lessons on the fundoscopic exam. and I think it's in number 4, and it tells the reasons to. It's in video and other resources, and it's a poster for the red reflex poster. So it gives the what you're looking for in a red reflex exam, and really good pictures there. So go ahead and review that a little bit. There's some good resources in there. That resource I told you about a few minutes ago with the antibiotic selection, it's also found here in your course, so you can have that. Okay, let's look at the quiz on the eyes. Hopefully there's a few more questions in here. So there's 8 questions in this, and I know that by opening my question completion status. A 36-year-old school teacher complains of a bright red spot on her eye for the past few days. She denies pain, visual changes, drainage, or headaches. She reports she's had a bad case of bronchitis with residual cough this week. So what is that consistent with? So the bright red spot is on her eye. So I'm thinking that it's on the sclera. So that excludes blepharitis, subconjunctival hemorrhage, maybe, uveitis, bacterial conjunctivitis, maybe. But this is more consistent with subconjunctival hemorrhage. So I'm going to choose that one. Okay. Recognizes the appropriate follow-up for this patient is eye drops, referral to a collaborating physician, patient teaching, or optometrist. I'm going to go with patient teaching. Antibiotics are not indicated for a subconjunctival bacterial conjunctivitis, and that would have the sclera completely, it would be mostly red all over, not just in a one spot. Okay, so it's not something that needs to be looked at by the physician or specialty care. An elderly woman is being seen in the office today for concerns about a triangular-shaped thickening of the bulbar conjunctiva. The lesion on is the right temporal side and is encroached on the cornea. She is without pain. What problem does she have? Pterygium? Blepharitis? No, that's chalazion. No, those are all on the eyelid, right? Pinguicula, maybe. Okay, so this is on the it's triangular shaped on the conjunctiva. Okay. When the nurse practitioner assesses for the red light right reflex in the infant, she is screening for blindness, ocular muscle impairment, cataracts. I think it's this one. You can look at that. Chart. A patient has timolol ophthalmic drops, that's a beta blocker, on his medication list. The nurse practitioner knows that atenolol is contraindicated or used with caution in the presence of verapamil, atenolol, yes. That there's contraindications for each one of those. Okay, so with each one of these, with atenolol, it's gonna be another beta blocker on top of the one that's already there. Both of them cause low heart rate, and also verapamil is a calcium channel blocker and can also cause the same thing. A patient presents with pain in the right eye. Which following below is the most worrisome to the nurse practitioner? Decreased extraocular eye movement, positive red light, no, that's good. Yellow drainage, maybe bacterial conjunctivitis, red eyelid and surrounding skin. So we're starting to look at cellulitis around the eye, right? So, but you can have cellulitis around the eye, but if you have decreased extraocular eye movement, it's pretty serious because we're looking at a septal infection there. 17-year-old volleyball player with signs and symptoms of mononucleosis has a negative spot test. The nurse practitioner knows that early in the infection, this should be in the throat section, but the nurse practitioner knows that early in the infectious process, the test could be negative. That's true. Sometimes there's a delayed response there to antibodies or to detection of the antibodies. The patient with red sclera and yellow drainage, we know what that is in the clinic. The nurse practitioner should first assess a culture, extraocular movement, visual acuity, and this is about your advanced health assessment differential diagnosis, and we always want to assess visual acuity in a patient with an eye complaint first. Follow-up for somebody with a hemorrhage is patient teaching. It's a benign disorder. Pterygium is a triangular growth on the white of the eye that may extend into the cornea. Now you can see that I'm using definitions that are kind of consistent in most resources. So you'll look for those key words to help you in your clinical practice, but also on your boards that give you license to practice. Okay, when a nurse practitioner, the red light reflex, the cataracts are present. Timolol, glaucoma is managed by specialists, but also often have glaucoma patients in their primary care practice. Adding a beta blocker to timolol can cause dangerous hypotension, bradycardia, and heart block. Pain in the right eye, septal cellulitis, kind of what we talked about. If symptoms persist with pharyngitis, fever, fatigue, and lymphadenopathy, repeat the monospot. A patient with red sclera and yellow drainage, we want to check their visual acuity. So I think we got 100. Think about penicillin allergic. That is something you need to think about. And again, you can go back to that chart and you can see that if you have somebody allergic to penicillins, they probably can't get cephalosporins either. So then that takes you down to, you might do a Z-Pak. It's not going to cover that beta-lactam. So you're kind of getting a little bit, when you say that somebody is allergic to penicillin, they better be allergic. And if you have a child that is prescribed an antibiotic for a virus, when they have a virus, and they, as a natural course of the disease process, they end up with a rash, and it was from the virus and not the antibiotic, we don't want to say that they're allergic to penicillin unless we really know it. And I would recommend that you go ahead and do testing, the IgE testing for penicillin allergy. Really see if they have a penicillin allergy, but just keep in mind that if they do have a reaction, a true reaction to penicillin, that the reactions may get worse over time. So it's not like, well, we just had I don't know. I feel really funny about prescribing cephalosporins, but there are a lot of people that they do that assessment and say, if it was just a rash, well, then that's not an anaphylactic, so I can go ahead and use that. So. All right, here's a good chart on preseptal versus orbital cellulitis. Those key diagnostic, they're both, serious problems, and you're going to need to look at the management of each one and also know the key difference between them, and that is extraocular eye movement, and that's an emergency, immediate referral for ophthalmology. Sometimes on the boards, they like to ask about this neonatal conjunctivitis, and I'm not quite sure about it, but they like to ask about the gonorrhea stuff, the congenital gonorrhea infection. So be sure and think about that, and let it be on your, some resources say in a baby less than 20 days, and some say in a baby less than 10 days. So think about that and just have it be on your radar if you have a tiny baby with bacterial conjunctivitis. Okay, this is a talk, we're starting to get into the throat here. We have some information here on a 4-year-old with scarlet fever, which is group A beta hemolytic strep complication. And when I've seen scarlet fever in children, I've seen the fine sandpaper. It's just kind of rough when you feel it, but it kind of looks like a sunburn. So that's what, you have a baby that's ill. Or a child, and they have maybe vomiting, a fever, and they don't always complain of a sore throat. Maybe their chief complaint might be my stomach hurts because they're nauseous. So don't discount. If you have a baby that looks sick or a child that looks sick and they have a fever, then put this on your radar there. Put strep throat on your radar, even if they don't complain of a sore throat. Now, chronic nasal congestion, That's a problem that it's kind of a diagnosis of exclusion after you've gotten rid of everything else. So one thing that is a reason for it is excessive use of like neosporin or neosynephrine nasal spray. That those are called topical nasal decongestants. And if you use those more than a couple of days, you can get rebound basal congestion in the nose and the nasal tissues. Okay, now epiglottitis is a bacterial infection, and it is really an emergency. That's the one where you're going to hear stridor in the airway, and it's an emergency transfer. And call 911 if that is and know those key diagnostic signs of drooling and things like that. Uh, Drooling is considered the kind of the diagnostic for epiglottitis and the stridor, and also in peritonsillar abscess, kind of the diagnostic key is that hot potato voice. Now I can't really, I mean, if you haven't heard the patient's voice before, I'm not sure that I would recognize it, but it's a hoarse voice. And also they're going to have like their tonsil is going to be covered in exudate, and maybe their pharynx also, and also their uvula can be displaced to the opposite side. So those are both referrals. Those are not going to get well treated in primary care. They need to be epiglottitis needs to be treated in the hospital, and airway support, and also the peritonsillar abscess usually needs to be drained. So that's specialty care. Think about this case right here. The male presents with green nasal drainage. Now, people like to say, what color is the nasal drainage? And that's not always diagnostic, but what we want to do when somebody has an upper respiratory infection is we want to keep the nose draining. We don't want to stop it up by using first generation antihistamines like Benadryl and things like that. That will stop the secretions, but will also stop the drainage. So we want to keep everything draining. The only time that I make an exception to that is if, the client might say, well, I'm drowning. They have so much drainage that it's going down the back of their throat when they're sleeping and stuff, and I may give them a little bit at night. But other than that, you want to keep it running, and also know that, what they're coughing up or what they're coming out of their nose, you want to keep those nasal secretions thin. But the color is not always real significant. Sometimes it just means that it sat there for a while, and that is a problem because you want to keep things draining. So you want to keep them thin and draining. Okay, acute sinusitis, it usually occurs after another disease. Okay, so somebody's gotten a cold or they have chronic allergies and they have a flare up, or 10 days later or after a week, they come in and they've tried everything they can, and now they've got this, usually on one side or frontal headache, and they may have a fever, that type of thing. You can look at the kind of the signs and symptoms, and that is different from an upper respiratory infection. A lot of times I see students in their typhon diagnose acute sinusitis when the patient has only been sick for 2 days and they really have an upper respiratory infection. So be sure and know the difference between those two. Okay, so here's something on rhinitis, and you're going to see a lot of that. So just understand whether it's allergic, infectious, and then just for no reason. Now, I know that there are people that they can react to triggers and not necessarily have an allergy. It's like if you were to be caught in a fire and you breathe smoke, you're going to have a reaction to that smoke, but it doesn't mean you're allergic to smoke. It's a noxious fume. And so sometimes these are just irritants. They're not, you can get rhinitis from irritants, and it doesn't have to be a true allergy. So think about that when you're assessing your patients. Okay, so know the center scale. We had a student report that they used the center scale, and know what it's used for, and know when to culture for beta hemolytic strep, know when to treat empirically and what to treat with. Okay, let's take the test on the throat. Let's see how many questions we have. Okay, 4 questions. A patient's exam is consistent with streptococcal throat infection. The rapid strep test completed in the office is negative. The nurse practitioner should repeat the rapid strep test. I don't know what would change, but look at those specificities on or sensitivities on those tests and read the box when you're in the office, and some of them are as low as 65%. So, you're only going to get what you're going to get with that sensitivity. You can order a throat culture. That sounds pretty good. Send the patient home with symptomatic management. So streptococcal throat infection, they're ill, right? If your exam is consistent with streptococcal throat infection, you want to kind of get to the bottom of it. So I wouldn't send them home with symptomatic management and complete a mono strep test. Well, maybe, but remember those key diagnostic things for mono are the 3 F's, and I got that from a good teacher, pharyngitis, fever, and fatigue, plus an L, lymphadenopathy. So but if your patient's exam is consistent with streptococcal throat infection, then you probably wouldn't want to do a mono spot test right now. You could, but the next best thing is to order a throat culture. A CBC is collected on your patient and run in the office. The leukocytes are elevated. This most likely represents bacterial infection, resolving infection, viral infection. Well, you don't have the neutrophils and you don't have the rest of it. So, or the lymphocytes, you don't have the rest of the information, so you can't know if there's a shift to the left or the right. An 18-year-old male is seen in the clinic for fever, fatigue, pharyngitis, and lymphadenopathy. Oh my goodness, we just talked about that. The nurse practitioner should use caution in exercise caution in prescribing. Now, these are key diagnostic things for mono, and I'm not sure that you pick this up, but prescribing a penicillin or amoxicillin is going to be a problem. This is ampicillin, but it's really amoxicillin because it can cause a rash. Group A beta hemolytic strep is characterized by gradual onset of sore throat. False. It's pretty rapid. The mono is a little more gradual. Okay, let's save and submit, and let's see how we scored. I'm going to go right down here to OK and view my results. Okay. Second swab for cultures. Leukocytes are elevated or viral. We don't know lymphocytes or neutrophils, so we need to know that to evaluate that. And then penicillin should be avoided. Ampicillin rash. Guess it is ampicillin. You need to look that up. For some reason I'm thinking amoxicillin, but since I put that in there, it's probably ampicillin. And penicillin is also included in there, but it's a milder rash. And they don't really know the mechanism for that. GAS is usually a rapid onset with multiple symptoms and a sore throat. All right, let's take the nose quiz. Let's see if there's how many questions are in there. Looks like I only have 2. Okay, a 70-year-old man presents in the office with a history of a cold last week that went away. So he has a history of a cold. He's now complaining of severe pain to his right cheek and upper right molar that worsens when leaning over. And he has a low-grade temp. He's allergic to penicillin. Does that matter? Yeah, if you're going to prescribe medication. What is the most likely diagnosis? So allergic rhinitis is usually drippy, clear drainage. Doesn't usually have a lot of pain, itchy eyes. Migraine headache. Usually the pain, migraine headaches don't really happen in the cheek. You can have a cluster headache behind the eye, but this isn't really consistent with that. Acute sinusitis, well, he had a disease, he had a cold last week and it went away, and now he has extra symptoms. Could he have dental caries? Yes. But we would have to look in his mouth to see if something going on there. But remember that a dental abscess can cause a sinusitis. So you don't discount sinusitis because they also have an abscess, because they can go together. So I'm going to choose acute sinusitis based on those criteria. First line drug for management of allergic rhinitis is a decongestant? No, we don't. That's not first line. A topical nasal steroid, maybe. First generation antihistamine, second generation antihistamine. Both of those are on the radar, but the evidence is for a topical nasal steroid. Don't hesitate to contact me if you have questions.